Dear colleagues, I'm delighted to be invited for the 11th Scholars Conference. And my name is Vladan Novakovic. I am faculty in Ichan School of Medicine, Mount Sinai, New York. And my title of my presentation is Person-Centered Medicine in the Age of Artificial Intelligence, Preserving Human Meaning in Psychiatry. The rapid integration of artificial intelligence into healthcare presents both transformative opportunities and significant ethical challenges. In psychiatry, where meaning, narrative, and relational dynamics are central, the risk of reductionism is particularly pronounced. Person-centered medicine, grounded in 8 core tenets, provides a comprehensive ethical framework to guide AI integration while preserving human dignity and meaning. This paper will examine how person-centered medicine can inform and develop and use the clinical AI, ensuring that technological advancement enhances rather than diminishes the human dimensions of care. Artificial intelligence is increasingly embedded in psychiatric practice, offering improved diagnostic precision, predictive analytics, and personalized interventions. However, its expansion raises fundamental concerns regarding autonomy, dignity, bias, and the potential erosion of the person-clinical relationship, or patient-clinician relationship, rather. AI systems excel at pattern recognition, but remain limited in addressing value-laden, existential, spiritual, and relational aspects of care. Emergent consensus suggests that AI should function as a collaborative tool that augments human judgment, rather than replacing it. Without a guiding ethical framework, there is a risk that efficiency and standardization will overshadow meaning, personhood, and context. Person-centered medicine offers a structured response to this challenge. The following are the 8 tenets of person-centered medicine in AI era. Number 1 is ethical commitment to the whole person. Person must be understood as integrated bio-psycho-social, spiritual, and ecological, but also cultural beings. AI systems, while powerful, tend toward data abstraction and categorization. A person-centered medicine approach requires that AI outputs be contextualized within the full lived experience of the patient, preventing reduction to algorithmic profiles. Number 2 is respect for dignity and personhood. Dignity remains a foundational ethical principle in medicine. AI deployment must avoid depersonalization, objectification, and bias that can undermine patients' identity. Human oversight is essential to ensure that technological processes do not erode respect for individuals. Number 3 is relational autonomy. Autonomy is relational, shaped by interpersonal, cultural, and clinical context. AI-driven recommendations must be integrated into shared relational processes rather than presented as authoritative conclusions. Preserving dialogue is critical to ethical care provided. Number 4 is shared decision-making. AI can inform clinical decisions but cannot determine what is meaningful or acceptable for a given patient. Shared decision-making remains central, integrating evidence with patients' values, preferences, and tolerance for uncertainty. Number 5 is collaborative diagnosis and formulation. Psychiatric diagnosis is not merely classification, but interpretation. AI may identify patterns, but meaning emerges through collaborative formulations. Patient's narrative must remain central to diagnostic understanding. Number 6, integration of science and humanism. AI represents the expansion of scientific capability, but its application must be balanced with empathy, presence, and moral judgment. Evidence-based care must remain inseparable from humanistic practice. Number 7, cultural humility and contextual sensitivity. AI systems risk embedding cultural bias due to non-representative data sets. Ethical implementation requires continuous attention to cultural context, diversity, and reflexivity in both algorithm design and clinical use. Commitment to equity and justice. AI has the potential both to reduce and to exacerbate disparities. Without deliberate safeguards, algorithmic bias may reinforce inequities in care. Person-centered medicine requires active advocacy to ensure equitable access and fair outcomes across populations. In my discussion, AI and the preservation of human meaning, the central ethical tension in AI integration is not technological capability, but the preservation of human meaning. Psychiatry uniquely depends on narrative, interpretation, and relational depth, domains that resist quantifications. AI can support these processes but cannot replace them. There is increasing concern that over-reliance on AI may lead to epistemic injustice, where patient experiences are undervalued relative to algorithmic outputs. Maintaining epistemic humility, recognizing the limits of both AI and clinical knowledge, is essential and crucial for ethical practice. Person-centered medicine provides a safeguard against these risks by anchoring care in the person as a whole rather than the system. It ensures that AI remains a tool within a broader moral and relational framework. Implications for clinical practice and policy. AI should be implemented as decision support, not decision authority. Training programs must emphasize ethical reasoning and relational competence. Governance frameworks should prioritize transparency, accountability, and fairness. Multidisciplinary collaboration is essential for reasonable and responsible AI integration. In my conclusion, artificial intelligence will continue to transform our field, to transform psychiatry and medicine as a whole, but its value depends